Hey guys, it's Ryan. Let's keep it going and pick up with anterior skeletal crossbite. So this time, instead of talking about a couple teeth that are off, the whole skeletal complex is off. So the mandible could be excessive, the maxilla could be deficient. It's basically class 3. So one way to treat this would be taking a growth modification perspective and using reverse pull headgear. So headgear is typically like pushing, towards the head, you'd think. So reverse is pulling away from the head. And so you'd have to do this about age 7 or 8 before the skull fissures fuse. And this would be mostly for maxillary deficiency because you're pulling the maxilla forward in this example. Chin cup would be for mandibular excess, and it's pushing the mandible backwards. And this is not really used anymore. It's not very effective at all. And I can tell you because I had this treatment modality and it did not help whatsoever. And I still have a class 3. Anyway, another way to treat, which is what I wish I had, were class 3 elastics. And if you wanted to attach with a fixed edgewise appliance, so braces, if you wanted to attach between two brackets, it would look something like this, where you attach further back on the upper and further forward on the lowers, and you could see how this would pull the mandible back / pull the maxilla forward. Also, once you reach age 11, your bone is mature enough to use a temporary anchorage device, which could be like a bone plate or something, which is super cool. And you wouldn't have to worry about like anchorage or extrusion or any other like sequela of using elastics. You could just attach a bone to the maxilla and just pull it forward. So that's pretty cool. And I wanted to just note quick, elastics are named after the problem that they're trying to correct. So class 3 elastics would be to correct class 3. Alright, so let's switch gears and talk about posterior crossbite. So this is, again, in the transverse, right? We talked about anterior crossbite, which is in the anterior-posterior plane. Posterior crossbite is talking about posterior teeth that are improperly overlapped in the transverse plane. So we can use a rule of thumb, which is basically put the thumb to the roof of your mouth, and if it's a normal palate, it should fit. So if we had a crossbite, posterior crossbite, and a normal palate, that means that it would be a dental crossbite because the teeth must be tipping lingually, otherwise how else would they be improperly overlapped? If it's too narrow, it's a narrow palatal vault, it would be like a class 3 problem where the maxilla is too constricted and the mandible is wider, and so those teeth are going too far buccally. Now, this could be a result of a thumb sucking habit, which we'll talk a lot more about when we talk about anterior open bite. But thumb sucking habit can lead to maxillary constriction from increased tone of the buccinator muscle, and this typically leads to a unilateral posterior crossbite. So it's like a functional shift when you bite down and then your teeth slide to one side, and on that side, the mandible is like moving to the right, so that your right side's in crossbite, for example. And this could lead to tooth wear, dental compensation, crowding. So again, untreated functional shift is really bad. So we want to treat that ASAP. So let's hone in on posterior dental crossbite. Because remember, everything has like a dental and skeletal component. So this would be lingual tipping or palatal tipping of maxillary teeth, and treatment would be expansion lingual arches, which do a slow, continuous expansion of the teeth outward. And this is for primary and early mixed dentition. So think, like around, 5, 6, 7, 8, somewhere around there for the age. All right, so here's our first lingual expansion lingual arch. The first expansion lingual arch is the W arch, and that kind of makes sense. It looks like a W here. This is my crude drawing of a W arch. It's usually a 36 milli-inch stainless steel wire, This is used maybe age 8 to 11 when the mid-palatal suture is still open, so you can get away with using a continuous light force. And we'll talk about having to use a heavy force once the patient gets older later on. But for now, patient's still young, we can get away with a light continuous force. The W arch can do about 2 millimeters per month, 1 millimeter on each side, and it may open the suture slightly as a byproduct of it moving the teeth apart. So let's think back to our paperclip example, and here's our original structure of the metal wire, and we can push this arm in while we squeeze it into the palate. We could squeeze this arm in, and then also squeeze this component. And so it's going to look something like that. So when we, here's how we started. I just love this animation. Sorry. And then when you squeeze it together, you get something like that. And so you can imagine that if this arch wants to revert back to its original structure, it's going to push outward. And so it's kind of cool because it pushes both on the posterior and anterior aspects of the arch. So this component here, if this part is bent, it's going to be pushing on the posterior aspects. And then if these components are bent, it's going to be pushing on the anterior aspects. So the whole thing combined is pretty genius. It works. It's pretty cool. I also apologize in advance for using permanent dentition. This is, again, should be primary or at least mixed dentition. So just ignore that. But otherwise, this is accurate to how it would be working in the mouth, theoretically. Okay, and then we have the quad helix, which, if you notice, it's pretty much identical, except it has, well, 4 helices, hence quad helix. The 4 helices, again, we're adding length, so it's more springy, has a better range of action, which means that it's going to work over a longer distance. It's going to be able to move the teeth further for longer without having to be reactivated. And this treatment modality takes about 2 to 3 months, and then afterwards you want about 3 months of retention. And so you just leave this appliance in the mouth. Just leave it in passively for retention. So you wouldn't leave it active because you don't want to push the teeth further apart than you intended, but you could just leave it in the mouth passively. So here again, it's going to be pushing outward when it's activated. And then another option would be cross elastics. So again, elastics are named after the problem that they're fixing. So cross elastics would be for crossbite. And this would be more for like unilateral or individual teeth. It's also used in like adjunctive therapy for older adult patients. And so you would attach it to the mandibular, the lingual side of the maxillary teeth, the buccal side of the mandibular teeth, and they would kind of pull the teeth back towards where they're supposed to be. You could also use a mandibular lingual arch to stabilize the lowers and then focus most of your movement on expanding the upper teeth buccally. This also tends to, as you could imagine, because of the forces, it could cause some extrusion, which would be very bad for an open bite because you don't want to open the bite further. And elastics are usually in the 150 gram range, so that's about what you want for this treatment. Alright guys, I think we're going to stop here. We'll pick up next in the next video talking about posterior skeletal crossbite. So thanks for watching. I'll see you guys in the next video.